Hey gang, it is Wednesday and I am your host, Dr. Jeff Horowitz. I apologize, Dr. Chad Duplantis and Dr. Jennifer Bell couldn't be with us tonight. So for the next 60 minutes, you are stuck with me, Dr. Jeff Horowitz. Actually, I'm kidding. I'm Dr. Chad Duplantis. You guys know me. You guys know Jeff Horowitz. Jeff is in Ireland. He is actually working on finding his golf game. I think he is chasing Rory McIlroy, and he is looking for Irish whiskey and trying to have a really good time. But anyhow, tonight you are really stuck with me and my good friend, Dr. Jennifer Bell. And that's about it. So sorry, my intro sucked compared to Jeff's, but you know what? It is what it is because this is what you get and you don't get upset. How you doing, JB?
You don't pitch a fit, right? I'm good. Just trucking along. How about you?
I am doing just dandy. Just dandy.
So I've been watching or kind of seeing a bunch of stuff on Facebook and different groups, and everybody's talking about September sort of being slow and kind of coming off of an August that wasn't super busy either. How's it feeling in Texas?
I would say it's slower. I wouldn't say that it's slow, but I would say that it's slower. I mean it, and honestly, you find yourself saying this every now and then and you hate it when you find yourself saying this, but I'm going to say it's welcome.
Yeah, no, I get it. We need
It's
to learn to
welcome.
lean in and embrace when we have
Yeah,
those down
I
moments.
mean, obviously, yes, we love the busy times. We can't stand the dead times, but I appreciate the reprieve and the slight slowdown.
Yeah,
I don't want it to stay like this forever, but
I think our teams do too,
yeah,
because we
they
push them
really
pretty
do.
hard.
They really do.
So yeah, I agree. We've kind of felt similar. And I've started to see some of my first COVID cancellations, somebody testing positive for COVID and can't come in. So those are starting to ping back up on the scoreboard as a reason for not coming in again too. So I'm ready to talk the news. Are you ready to hear the news?
I am. I will let you talk the news. So, hey,
Okay.
folks, here's JB with the news you can use.
Drum roll. That was my drum roll, which kind of looked more like a sprinkler. I'll work on that for next time. I have so many faults. Okay, let's dive into the dental news for this week. Interesting article that coming out of Norway, where they are looking at new treatment modalities for burning mouth syndrome. It's super interesting that this story came out because when we opened our practice back in 2010, and we had a few patients that came in for burning mouth, and we were seeking guidance from oral medicine experts to help guide in our decision making. Do we need to do pharmaceutical prescriptions? How do we guide these patients to get some relief? And the recommendation at the time was a Tabasco sauce and baking soda mixture in water, and do like a swish treat of the tongue a couple of times a day. And I will tell you, hands down, it worked. So if you want the recipe for that particular concoction, I can certainly share it with you. Well, lo and behold, there's more research coming out now that actually the combative or opportunity for therapeutics for burning mouth is coming from capsaicin. We know capsaicin to be the element within peppers and other hot foods that creates that burning sensation in the mouth. Oddly enough, it is starting to show that capsaicin may be a key to potentially being able to treat burning mouth syndrome. There are some countries that are using it as an off-label use, but now there's more momentum to try to get capsaicin approved for oral mucous membrane treatment so that we can treat burning mouth syndrome. I thought that was super interesting and only validated this crazy thing that I learned, 15 years ago about Tabasco and baking soda being this magic concoction for burning mouth syndrome. I will absolutely put the recipe up for everybody. Second news story of the day. I thought this whole synopsis of data was super cool. So let's go through a little bit of data points. I want to give you kind of a brief update of where dental schools are and what the future supply of dentists look like. And this is provided to us by the ADA. 10,877 is the current shortage of dentists in the US, according to the Health Resources and Services Administration. That is based on a dentist per X amount in the population. Currently, we have 536 dentists in the US. That is up from 165 in 2002. 60.8 is the current number of dentists per 100,000 in the US population. The projected number in 2040, it is projected to be 67 per 100,000. So we're going upwards. Hopefully, I think, and the intention is to close the gap of the shortage. Last year in 2022, there were 6,745 new dental grads that entered the marketplace. That is up 7% from 2018. 6,500 is the total number of first-year enrollment in 22-23. That is up 4.2% from 2018 to 2019. 22 versus 7. That's the number of dental school openings compared with closings in the last 50 years. The last school to close was in 2001, and that was Northwestern University Dental School. And the most recent opening of a dental school was Kansas City University College of Dental Medicine, which opened in June of 23. 40% is the share of dentists age 55 and older, which reached a peak around 2013 to 2016. I'm guessing a good number of those individuals left the marketplace during COVID. 88% is the percent of inflows who have been new U.S. dental school graduates in the last 10 years. The remaining inflows are foreign trained dentists, established dentists who reactivated an expired license, and dentists who came out of retirement. And the last statistic, 48.4% versus 51.6%. Male graduates versus female graduates in the year 2021. A lot of interesting statistics that we could glean from that particular amount of information. Certainly does look like the marketplace is pushing for more and more dentists to be in the population. I think there is some concern from those who lived through the 1980s and saw many of those schools close, and we sort of shrunk back the number of dentists we were putting in the marketplace. Will this be a repeat performance? Too early to tell quite yet, but it does look like, at least if you are operating in highly competitive areas, that competition is probably only going to get worse, at least for the foreseeable future. The last two items push us right back to DC with some legislative issues. It's been kind of quiet for the summer, but they've decided to pick it back up. The first was a notification that came out from the House Ways and Means Committee Chairman, Jason Smith, who released an request of information or request for proposal from anyone who wanted to share information about access to care issues and disparities in healthcare access throughout the U.S. and underserved communities. That RFI is due by October 5th. So if you have an interest or are participating in community health centers or in programs that are helping serve underserved communities in an impactful way, it would be wonderful if you could share that information with the House Ways and Means Committee Chairman Jason Smith. And that information is available on the AGD advocacy page, and I can share that for everyone if you're interested. Why is this important? My guess is that this is coming on the heels of a pretty active season for access to care and bringing up the workforce population in the medical field, dental being included. There is another bipartisan bill that came out just this week called Lower Cost, More Transparency Act. It is a bipartisan supported piece of legislation that is intended to address both workforce disparities in underserved communities, but also transparency in pricing, and to try to help improve the access to care through pricing structure for patients. So it's a multifaceted bill. It's trying to accomplish quite a few things in the healthcare industry. My guess is some of this inquiry coming out of the House Ways and Means Committee has a lot to do with this particular bill that came out this week. There seems to be a lot of interest in access to care in the medical industry, and there's definitely a workforce compression. It's not just dental, they're seeing it in medical as well. And I think even as a consumer, I'm feeling it When you try to book an appointment now with a physician, you could try today to get an appointment for next summer as a new patient. So there absolutely is an access to care issue. What the options will be to solve it is still to be determined, but the legislature is taking it up as a concern to see if they can find answers or provide funding and support in those areas to improve upon those programs that seem to be working for their communities. So with that, that's the news.
As always, just so fantastic. And you know what? You said a word in there that I just have to bring to your attention. You said the word disparities.
Uh-huh.
And this is so weird, but as I looked down, Inside Dentistry was on my desk and it said addressing disparities in oral health. How freaking weird is that?
Well, so this Oral Health Care Act and access to care has been going on most of the summer, but it's been pretty quiet. And now we're seeing it peak back up again. I think the reason it's getting such a stronghold is because of the medical disparity. I mean, dental does have a pretty challenging workforce issue currently going on. I'm not so sure it's dentists as it is support staff, but medicine is losing physicians in all facets and specialties. And so there is a pretty significant compression happening in the industry to try to increase the workforce and access to care. So, and that is in all communities. You know, it used to just be that we were focused on these underserved areas because physicians and dentists and optometrists just didn't want to live and work in those communities. That the access to care issue now is urban and rural and many places in between, just because we've lost so many individuals out of the medical field. So who knows what this will, you always have some concern about regulatory issues that will come along with this that just make doing your job a lot more difficult. Never really know how these things are going to shake out, but I'm all for transparency, and I'm definitely all for, some of these antitrust and fee knowledge laws and things that are currently in place that don't allow dentists to be competitive with one another. I would love to see the marketplace open up a bit on that.
We got a freaking awesome guest tonight, and I would like to bring her on. Is that okay with you?
I would absolutely love it.
So this guest is a person that JB was like, hey, does anybody know Carla Cohn? And I was like, me. And Jeff was like, yeah, me too. But, she likes Chad better than me. And I was like, oh, okay, that's right, Jeff. Carla does like me better than you. So anyhow, all kidding aside, I've always been fascinated by what Carla does. So let me introduce her real quick. Carla is actually a general dentist. And I say actually because there's so many people that think that she's this pediatric dentist. And I would say that she has just devoted her practice to children, which is amazing. She does a private practice in Winnipeg, Canada. So sorry, not sorry. But it's called Kids Sleep Dentistry Winnipeg, Western Surgery Center, and Kids Dental in Winnipeg. She's published several articles. She lectures all over the world she does webinars, she does live courses. She enjoys teaching, and she's a fantastic educator. She's an active member of several dental organizations. She has been invited as a fellow to the Pierre Fauchard Academy and the International College of Dentists. And she has been recognized as Dentistry Today's leader in continuing education multiple years in a row, as well as a top 100 doc. I'm honored to call her my friend. I've met her. I've met her husband. I know about her kids. I've seen pictures of her dogs. I just love Carla. Who wouldn't love Carla?
Chad, thank you.
It's all bullshit, Carla. I'm teasing.
I was thinking maybe you ran out of people to interview. You finally got me on.
No, it's so funny because JB really, lately we've seen so much of you on social media, and it's like JB's like, we got to get Carla on. We got to get Carla on. And I was like, all right, let's do it. So anyhow, I just reached out to you, and I'm so privileged that you were just like, yeah, I'll totally do it. So thank you so much. It's an honor to have you.
Anything for you guys. I'm happy to be here. Thank you for inviting me. Thanks for having me. It's a pleasure.
Well, I always thought that, and I'm assuming, correct me on this, but you did not do a pediatric residency per se, correct?
That's correct.
And to me, I think there's so many people that see how amazing of a kids dentist that you are. I mean, you love kids, you love working on kids. So how did that come about? I mean, did you just ever do regular dentistry before you started treating kids, or what happened?
I saw a couple of regular people. I finished dental school, and I did, at the time, there was a hospital internship at Children's Hospital for a year. So I did that internship, and then I left that internship with the love of seeing kids and, knowing what to do and how to do it. And I entered into private practice after that. I did see a couple of adult patients. And I remember to the minute, clear as day, the adult patient that pushed me over the edge and made me realize that this was just not for me. That kids, the secret is that kids are the best patients. And I think I might have just let that secret out of the bag, but it's true. I love seeing kids. They're the best. I love them. I love their teeth. I love just treating kids. So at that point, I decided I'm limiting to kids. This is what I'm doing. And I never looked back. And that was a few decades ago, because, I started doing this when I was about 9 years old.
Yeah.
Of course.
Yeah.
Now, I don't want to give your age away, but did you and Paresh graduate together?
We did. Now, Paresh is much older than me.
Of course he is. I knew. I mean, he started dental school was a second career for him. I mean, dentistry. Yeah. I mean, he was in oil and gas, taxi driving, that kind of stuff, and then he decided to go back at about 40 or 45, and so.
I knew this was going to be a good night, Chad. I knew it the moment you said yes.
And then there's that Tim guy, and Tim, I mean, definitely dentistry was a second career for him, because when I saw pictures of Tim Dumore from dental school, he already looked like he was 50.
Yeah, those are my classmates, and they are a bit older than me, but not a
of course. Do you still keep in touch with them?
I do. They're still some of my closest friends, and we've been together for a long time, a lifetime or two. Well, they're great people, really.
You may not know this story, but several years ago, I treated Paresh and Tim and a couple of your other classmates to a football game in Austin, Texas, which was an absolute blast. So awesome. It was a wild time. I mean, they had to let everybody know that they were from Canada, of course, but the accent didn't give it away enough. But JB, I'm going to let you take the floor, because I have a lot of questions for Carla, but I don't want to hog the night.
Yeah. So I think for our listeners, while you treat all kids, they come with these gnarly little things attached to them called parents, who are still the adults in the room that, can be challenging at times. Maybe give us one or two best strategies, tips on managing both the patient as well as their family members that might accompany them to their appointments, or, obviously are their custodians and want their best care to be managed.
Of course. And that's the biggest challenge, is to be treating your patient, but to be communicating with the caregiver that's got the ability to make the decisions, and to be able to create the realistic situations and scenarios for the parents, so that they understand what is going on. And a lot of times parents come in and they have an unrealistic expectation of what their child is able to sit through, or what we can accomplish. And one of the things that is key to seeing kids and to managing the parents is to knowing what to do when and what we can pull off, because the procedures aren't difficult. That's not the hard part about doing pediatric dentistry at all. All of our procedures are, the longest thing we do takes about 14 minutes.
Yep.
And I would never have the patience to sit through and do any of the things that you real dentists do on big people, but to be able to really negotiate the proper treatment for the child and to be able to explain to the parent why you're doing what you're doing for that child, and to separate the parent too when it's for the best interest of the patient, which is key. This is how we approach everything we do, from the treatment that we give to how we explain the treatment. This is all in the best interest of the child, regardless of what your expectations may be. This is what the child needs.
So with that being said, do you routinely allow parents in the room with the child, or how do you handle that? Because I know that's a question that comes up a lot. And
yeah. So I do. And I have to give you a little bit of history up until that point. So a couple of years ago, and you got to appreciate, I've been doing dentistry for 32 years. So a couple of years ago, I've always had, from the very beginning, an operating room component to my practice, where kids come in and we do their treatment under general anesthetic for reasons of their age, cooperation, et cetera, et cetera. A couple of years ago, I've limited just to that. So I'm speaking in the past tense when I'm talking about bringing parents into the room, which I did for 30 years. At the beginning, when we did this, it wasn't expected. Parents didn't expect to come into the room. You go with, times have changed, not necessarily for the better in some respects, but they would send their child in, listen to the doctor, and do as they say. And then, years go by, and then there was really a shift, probably, I would say maybe 15 years ago, where that was no longer the norm, and that was no longer acceptable. And parents were not just asking to come into the room, but demanding to come into the room. And I've always let parents come into the room. So they've always come into the operatory, and it is so much better on so many levels, and it counterbalances the bad part of it. The bad part of it is that when a parent is in the room, the child doesn't always listen to us as the dentist, right? They don't.
Right.
They need to take direction from us, and they're deferring to the parent. The parent is also sometimes telling the child, encouraging their uncooperative behavior. And
yes,
the child is on, going for their empathy. Oh, poor me. And so, but all of that is counterbalanced by the fact that if I have the parent in the room, number one, I've got the parent in the room. They can see what's going on. There's none of this conversation afterwards about what exactly happened in there and what was the behavior of the dentist and what was the behavior of the child. They're there and they're witnessing it. So that's a huge thing in today's society, in the world we're living in, that the parent be there. So I completely advocate for the parent to be there. And if you, I don't want to use the term, if you speak properly to the parent, we can actually work to their advantage of having the parent in the room, to the advantage of the child cooperating. We use the parent for distraction. We use the parent to calm the child down too. Like, there's been many times where we've had child that's just not cooperative because they're too upset. Leave them with the parent, step out of the room for a couple minutes, come on back again, and work it that way. So short answer to the short question is, parents in the room can be used to your advantage when we're seeing the kids.
Exactly. I think you got to almost manage the behavior of the parent more so than the child at times.
Absolutely. Yeah, absolutely. And they can see then what's realistic and what's not realistic. Why can't you do 8 cavities in one sitting? I'm like, well, this is why we're managing the child and the parent at the same time.
So that's a really interesting question. Okay, so speaking of how much you can do in one setting, this is my rule with children. My rule in my practice is that if they have a lot of work to be done, I will set a time frame rather than a set treatment plan and say, hey, we're scheduling an hour and a half for Joey. And if we're going to get done what we can get done, that's safe and that we feel is good for Joey. But that may be one, and that may be half of his treatment. That may be all of Joey's treatment. But the thing is I want to see how Joey's going to respond after that first hour and a half, and then we'll go from there. What are your thoughts on scheduling time for children?
So typically when we're seeing kids, we'll treat them, unless it's an emergency, unless there's something urgent. Typically we'll treat them like by quadrant. So we'll take a quadrant of dentistry and we'll do that. Depends on the child's temperament. So if you've got an easygoing kid and they're cooperative, you can take your pick and do what you want. But there's strategies to go in and sensitize children so that you'll go in to do an easier procedure. So say they have a couple of MODOs to do, and they've got a stainless steel crown and they've got some sealants. And nothing is painful, nothing's urgent, nothing's infected. So child's a little apprehensive. Go in and do some sealants. Let them win that appointment. You go in, you do something easy. It takes like 3 minutes to do a sealant, and they've left the appointment being the hero of the appointment. They've won. It desensitizes them to the next appointment where they can come in and you can do something that's a little bit more challenging, a little bit longer. So that's one strategy to do it. Other strategies are to do opposite quadrants at the same time so that you've got with an isolation device so that you've got this whole side of the mouth. You do one side of the mouth one day and then bring them back a couple weeks later and do the other side. So there's several different strategies, barring any infection or pain, where you can start and you can work to build the confidence of the patient, build the confidence of the parent, sometimes build our confidence too if we're not used to seeing kids. Start off with something easy. Don't start off with something that is technically challenging on a child, something that you need to keep completely dry in a wet environment. Choose your materials wisely too.
I love that answer. And I think, like I said, I try and do time, but that's just really on the kids with a lot of work, but I love quadrant dentistry. I love letting them win the appointment. What are some advances that you've seen in materials and techniques?
How much time have you got?
I know. Like when we got out of dental school, it was, if a child needed an MOD, it's a stainless steel crown.
Yep. Yeah.
And, I've really pushed the limits, I would say, on composites and other restorative materials on children. I do feel the need to etch the teeth a little bit longer, maybe, and, make sure that we have proper isolation. But what are some advances that you've seen,
So, when I finished school, it was amalgam, stainless steel crowns, or extractions, and
or pulpotomies.
So when we were doing pulpotomies, but pulpotomies. So for example, pulpotomies have changed completely in the last 10, 15 years, and then continuing to evolve. Formicresol, ferric sulfate, don't touch them anymore. They're gone. Now we use MTAs, but we'll use it in the form of TheraCal PT, so a calcium silicate, a resin-modified calcium silicate. That's a Visco product, TheraCal PT, for our pulpotomies. We'll use biodentine for our pulpotomies, and these materials will give us a more successful pulpotomy than our ferric sulfate and our formicresol without having any of the carcinogenic, possibilities of formicresol. So that's changed. Our crowns have changed. So I still do a ton of stainless steel crowns. Don't get me wrong. Still it is still standard of care, stainless steel crowns to do on a 3 surface or more. Like you were saying, 3 surfaces or more caries, we'll do a stainless steel crown, but we've got aesthetic crowns that are available now. The aesthetic crowns also, came out 10 years ago, 15 years ago. And our materials, the composites, just as they've changed for the adult world, they've changed for the pediatric world. So when you're looking at doing something like a big MO or a big DO, your materials are stronger than they ever were, but the tooth itself is still the same pediatric primary tooth, still doesn't have that strength. So, I mean, glass ionomers have changed, bioactive materials have changed. There's a ton of other resin infiltration has come into our world. So all of these things have made dentistry for kids so much better than it ever used to be. And local anesthesia too, not just the local anesthetic, but the delivery systems, all of these computerized delivery systems that we've got for our local anesthesia that are making things more comfortable. I could go on and on and on.
So you're an expert in this, and I'm just going to pick one. First of all, I'll pick two things. I notice you're using a lot of bioactive materials, which I absolutely love. Second thing is, tell us a little bit about if you're utilizing these computerized anesthetic delivery systems, which one have you kind of honed in on, and why do you like it? Because I think that's a hot topic in dentistry right now.
So I have the wand, like the STA, single tooth anesthesia. And I just got a CalEject. I have to trial it still, but it's in the box waiting for me to open it and trial. It's coming. So if you're interested, look on my social media, and no doubt I will post whatever I think on my social media about that. I think for kids that have, you get that kid into your office that's had the bad experience, they've been somewhere else and they're traumatized from whatever's happened. A lot of that stems from the moment they have local anesthesia. So they're expecting you to come at them with a syringe. I mean, dentistry is dentistry. If I go to you, or if I go to you, or you come to me, we all got the same stuff.
Yeah.
But that's one of the things that I find, and you probably find with your adult patients too, they're very fearful about the injection. And with kids, when they're fearful about something, they're, it's like, oh, don't touch me, right? Adults will, I think that they'll suck it up and close their eyes and hold on and do it. Kids absolutely won't let you in. So when you come in with a computerized anesthesia like the wand, I've got this little itty bitty needle it's not what they're expecting. It's not what they're expecting to see. And I can put it in place I'm not going to say half the battle. That's 90% of the battle, is to get the anesthesia next to where I'm about to inject. And then to be able to inject it computerized so that you're below that pain threshold is huge. So for those kinds of patients that we have that have had a bad experience or are very fearful of needles, it's a huge, huge game changer for our patients.
What about topical?
Okay, so topical, I do a compounded topical,
Okay,
and that's like the key. But so a couple of things about local anesthesia and topical. Number one, put the compounded topical on and leave it on long enough for it to actually take effect. That's huge. Don't just rub it on and then anesthetize the patient. So that's number one. Number two, when we have our general dentists that don't see a lot of kids, and you have a kid come in, remember where the apex of that tooth is, right? That's like the biggest thing when people are infiltrating and they're not used to seeing kids, and they're anesthetizing right under your eye socket, and the apex is 10 millimeters from the surface. Just remember where that is. And I infiltrate almost everything, mandibular as well, on a primary tooth.
So I'm assuming you're using a lot of Septicane.
Yeah.
Or Articaine, I should say. I'm sorry.
Yeah.
Going brand name.
Yeah.
Yeah. Love it.
Yeah.
Love it.
That's it.
JB, I'm going to let you ask a question because I've asked too many, but I got another one later.
Well, there's always, especially in the advancement side of things, I'm still I'm sitting over here processing the pulpotomy again. I certainly kind of have gotten away from, the traditional methodologies that we were using. But once you debride it, what's your heme control agent? What are you doing to calm the pulp down in order to use some of those bioactive materials to sort of rebuild those walls?
Yeah, so you need to change the paradigm in our heads, right? We're stopping the hemorrhage with pressure. And so I'll irrigate with saline, and then I'll take a saline-soaked cotton pellet and put pressure on there. You should need maybe a minute of pressure. And that also tells us the difference between a healthy pulp and an unhealthy pulp. Because when we're using hemostatic agents, or when we were using hemostatic agents to stop the bleeding and then go ahead and put in your IRM or whatever it was you were using, you're getting a lot of false negatives here, because the hemostatic agent was stopping the bleeding.
Mm-hmm.
A healthy pulp, pressure will stop the bleeding, and then you put your bioactive material on top of it.
So if pressure doesn't, if it doesn't respond to pressure, you're becoming more concerned that this is not a tooth that you could restore traditionally.
If it's a hyperemic pulp, maybe it's not restorable. Maybe this is an irreversible pulpitis. So I'll go in, take a little bit more of the pulp out from the canals, just with my big round burr, slow speed, and then try the pressure again. If after a couple times of that, it's not going, it's still bleeding, and you'll be able to, you'll see, is it active bleeding or is it oozing?
Right.
And active bleeding, like, forget it. This isn't going to work. I'm not doing this kid any favors by trying to put a bioactive material, MTA, calcium silicate material here. Like, let's move on. This tooth is done.
Do you ever use a laser in those instances to debride the pulp?
You can. I don't. I do have a laser. I haven't used it. You can use it. It's nice to use. It's an extra step. Bring it out. Use it. It's got a high success rate. So if you look at the literature and you look at the percentage success using laser for pulpotomies, it's got a fairly high success rate.
Is that just a traditional diode that they're recommending, or okay?
Yeah, it was just.
I've always wondered. I mean, I don't. If it's going to be a pulpotomy, I usually refer it to the local Carla in my neighborhood.
But that's what I'm here to tell you. You don't have to.
And now I've honestly learned so much in the past 5 minutes. And the thing is we do have a lot of wonderful bioactives out there, and
absolutely,
the thing is that if we've got these bioactives, why not use them to our advantages?
Can I jump in on that, Chad, really quick?
Yeah, of course you can.
Let's
JB,
come
please.
to those. I feel like there's been a little bit of a change in the methodology too on a direct pulp cap. If I recall from my education, if you go into a primary tooth and you have an exposure, they were typically taking it to a pulpotomy and stainless steel crown at that point, even if it wasn't hyperemic or you had the blush or the little bit of red, but it was manageable. They were still pulping the tooth and opening up. Any change in that because of the bioactive world now and our ability to manage that? What's the change in the thought process on that?
So that thought process still exists. That's still the standard of care. The recommendation is to still go ahead and do the pulpotomy, but there's evidence coming out that's showing more and more success with a direct pulp cap on a primary tooth. So the literature is saying that, with caution, that you can do an MTA or MTA-like substance for a direct pulp cap and have success. We're not there yet where that's a recommendation, but with the changes in materials, I believe that that's exactly where that's going.
Well, and does time frame factor into that as well? I mean,
huge.
Is the difference of saving the tooth for 6 years versus 1 year or 2 years, and you're just trying to buy time?
Absolutely. Absolutely. And, it's that same principle applies for, standard of care after pulp treatment is to do a full coverage crown. Standard of care for not to do a 3-surface intracoronal restoration. It's all relative to time of exfoliation. So if we have a kid that we've got a year to buy some time with, you can push that envelope and you can do things that you couldn't do for a 2-year-old.
Right. Yeah. Right.
I tell you, I'm learning so much.
He's taking notes, Carla. He never takes notes during these things.
That's
I'm learning so much.
Just come and spend a couple days with me.
Well,
I'm coming in the summer, though.
Yeah. Well, it's still summer here, technically.
Yeah,
You know,
yeah.
not
What is the just changing gears here? What's the temperature outside?
okay. Well, I can't tell you what it is in Fahrenheit. I'll tell you what it is in Celsius, and then I'll have to do my conversion here. So right now it's 19 Celsius, 18 Celsius, which is, hang on a
64,
second. Is that 64?
I'm guessing.
Yeah. Yeah.
Is it?
Whoa! That
Wow.
guy who knows nothing about nothing dropped
And I
You-
just
that major math
want everybody
on
to
us.
know I did not pick up my phone to check that.
I
That's
am I am impressed, and I bet you Jeff is speechless.
yeah.
That's amazing.
So with there's a question that came through, and I don't know who it's from. Oh, it's from our good friend Chris Robinson. Hey, Chris, it was good to see you in Tulsa a few weeks ago. Thanks for being a fan of the show, man. We love you. Anyhow, all kidding aside, Chris asked, what about a first molar endo on a 10 to 14-year-old? Do you do any of those, or do you refer those out?
Do I personally do it? No, I don't do it. But our endodontist is telling us that before you go ahead and do an endo, do a pulpotomy.
I think that was the question. So,
Or even a pulp cap, I would imagine, if it's
Yeah,
a light exposure.
Yeah, it depends
Yeah.
on the situation. So, and when I'm doing those, I'll do those pulpotomies with biodentin.
so okay, so let's take this case. You've got a 12-year-old, first
Okay.
molar,
Okay.
cleaning out caries, and all of a sudden you get the pulp horn.
Yep.
What are you going to do in that instance? It's just red. It's not like pulsating. It's not profusely bleeding. It's just red. You can see it. You know there's a little blood there.
Pulp cap it. I would pulp cap it.
And what would you pulp cap it with?
Again, with the biodentin.
Okay.
Yeah.
So and biodentin, humor me.
Tricalcium silicate. It's like an
Okay.
MTA-like material.
MTA.
That's
Okay.
a Septodont product.
What are your thoughts on? Okay, so let's say I get a situation like that. What are your thoughts on cleansing it with like an antibacterial
Yeah.
agent, such as let's just use Desensamax from Vista Apex, and then maybe a regenerative universal adhesive and a composite? Is that count? Is that not effective, or do you feel that you just cleanse it off? Do you cleanse it first with anything, or?
I would cleanse it with maybe a chlorhexidine.
Okay.
And
4%.
yeah, I wouldn't go ahead and put a composite over top of it, because I'm not confident that I'm not going to go back in there. And if I'm doing a pulp cap, I'm not confident I'm not going to go back in there and do pulpotomy. So instead of a composite, I'll put like a glass ionomer on there to give it some longevity, but as a temporary caries control, so that I can go back in and monitor that tooth. And it depends on the situation too, right? Is your kid cooperative? Are they from, do they have access to care? Like, so many things come into play on what exactly we're going to do, why.
All right. I got a question that just kind of came up.
From a friend, right?
But this is fun, but this question came up, and I'm going to ask it a little bit differently. What is your cement of choice for a stainless steel crown on a permanent tooth?
Okay.
You've got like the question was,
I have an answer for you. I was just,
yeah, but no, well, let me ask the question, because maybe it changes the way that you answer it. But if the caries were severe, would you place a stainless steel crown or a standard crown? And this is on that 10 to 14-year-old, let's say.
Yep.
And I get where they're coming from, because I also see, this person says, I see a lot of folks in their 20s to 30s who have had treatment performed when they were young.
Yep.
But it was never revised. And so I'll get a lot of patients, their late teens, early 20s, that have had a stainless steel crown on for however long.
Yep.
What cement are you using? What do you recommend? Do you do this? Just take it away.
Yes, and yes. Resin modified glass ionomer cement. You want brand names? The two that I use are either Fujisem from GCA or Reliax. It's 3M. And quite honestly, they're both They both perform exactly the same for this type of situation, and I'll buy whatever has better pricing that week.
Yeah.
And that's what, and I do stainless steel crowns on permanent molars frequently. Lots of molar incisor hypomineralization cases
Yeah.
that that's the only thing that's going to get them through, rather than in those cases that we don't want to extract the teeth, because we have lots of those situations too, where the molar incisor hypomineralization is so severe, it's just not even worth saving that tooth. So yeah, lots of stainless steel crowns on permanent molars, and resin modified glass ionomer cement is the cement of choice. And they can go the distance. They can go the distance until we want them to go the distance until that child is of age to be able to maintain a crown, an actual crown, a definitive crown, and to be able to have that crown, afford that crown, all of those reasons.
Well, okay. What about Ceramir?
Okay, so I use my Ceramir. I love my Ceramir. I do. I use my Ceramir for my zirconia crowns. So I do a lot of prefabricated pediatric zirconia crowns that are, you can do posterior, I can do anterior, I can do cuspids. They even have permanent molar zirconia crowns. So those ones I cement with Ceramir, mostly use Ceramir for that.
Now, I'm going to add, I don't want to offend anybody, but this is a show where we can do this. Are those New Smile? Is that New Smile?
Yeah. So New Smile is one of the brands.
Yeah.
There's other
Okay.
brands that are out there. There's Sprig, and there's Chang, and there's Kinder Crowns, and there's Acero Crowns. So all of those, I might be missing some. Those are the ones that I know of. But those are the crowns that are pre-veneered or prefabricated zirconia pediatric crowns.
Are you seeing the demand for that go up? Like
Yeah.
more and more folks are wanting.
Yes. Yeah. Yeah, absolutely. I mean, first of all, for anteriors,
Yeah,
I think
for
that
sure.
zirconia crown is the only choice for an anterior case. And I mean, I do the occasional strip crown still, but that is, rule is really the zirconia crowns. Those go the distance, and they look great, and they're easy to do. But posterior, they become more and more of a demand. And so, I'll do them if there's an aesthetic concern. Stainless steel crowns do the job. Aesthetic zirconia crowns do the job and give the aesthetics as well.
All right, I have a burning question. So SDF,
Yeah.
what is that application and current best practice use in your practice for the product? And sort of your decision paradigm of when you choose to use it versus doing restorative work.
Yeah. So SDF was a game changer when it came to North America. And you got to remember, it's not a new thing. Like, we had silver nitrate for like 100 years.
Yeah.
And then SDF came along. So for the uncooperative kids, it's fantastic to arrest caries until we can get in there and do something definitive. For kids that have poor access to care, for kids that can't afford it, for a kid you get in that you want to send down the street to the pediatric dentist and they can't get in for 6 months, or they can't afford to go. It's fantastic to arrest caries. As long as you don't have any pulpal communication, you're good. And of course, inform the parent that the teeth are going to turn black, dark brown. But we also use it for our cases where I don't want a pulp exposure. So like that molar incisor hypomineralization case, if I've got caries, I've got good walls to the tooth, and I want to do a definitive restoration, but I don't want a pulp exposure, I can put my silver fluoride on, and then I build on that. I'll build a sandwich onto that. In those kinds of cases, I'm going to use one of the products where I can mask it out, like the Revastar Aqua. The kids that are coming in, I'm using silver fluoride because they're uncooperative. I don't need to have that second layer of potassium iodide to mask out. I'll use here in Canada, that's Advantage Arrest is science. In the States, that's Elevate. So those are the situations where I'm going to use the silver fluoride, and where it has been a phenomenal tool for us to use.
Yeah.
I love it. And this kind of flew by. We're at our hour mark. I could go another hour. I honestly have learned so much. I'm very excited, and I want to have you back for sure. But one of the things that I would like to share is your upcoming course. So tell us a little bit about this before we close.
So this is coming up in a few weeks. It's in Vegas. It's just off the strip in Vegas at MediDenta. MediDenta does handpieces and endo stuff. They do prophy things, hygiene things. So they've just built a brand new educational facility. This will actually be their first course that we're holding at that facility. So I'm going to do a full day hands-on, and that hands-on we're going to run the gamut of talking about glass ionomers, composites. We'll do intrachromal restorations. I'm going to do those zirconia crowns. So we're going to have the participants actually come in, and I work with typodonts. This is how I run my hands-on courses. We work with typodonts. Attendees will cut the teeth and cement the crowns. So I've got stuff coming in from about 5 different companies. We'll talk about pulpotomies, all of the new innovations, a lot of the things that we were talking about today. So this is my CE platform is litsmileacademy.com. That QR code will take you to the ticketing site, and there is a discount special for you. And the discount code is LIT250. You get $250 off the registration. So I'd love to see you all there. And of course, I have a limited number of spaces for a hands-on course. So don't wait. This is like literally around the corner.
Well, I tell you, this is really exciting. And the fun thing is that Carla, I've known you for a long time. I don't know that I have ever really, I don't know if we've ever gotten this deep into pediatric treatment, and it was fun. And I know you're a brilliant educator. I know you do a wonderful job.
Oh,
and I think there's so many people that maybe just don't know how to treat kids, and so they just kind of refer. So
yep.
I learned so much tonight. And to answer Jennifer's question, I just want to tell you all that, yes, I was taking notes and I was Googling the spelling of most of the things that she talked about. I'm teasing. They always joke.
You won on the math for tonight. You can hold your head high.
Yeah.
I will close with it is 64 degrees in Winnipeg, Canada. I would also like to tell you all that they are not composites; they were composites.
Oh, right. Sorry.
And Carla, I need to go see your husband for an adjustment because my back is freaking killing me.
Up here. That's it.
But thank you so much for spending the evening with us, and it was wonderful to see you. We love you, we miss you, and thank you so much.
Right back
really
at
appreciate
you.
it.
Thank you.
All right. Well, we'll talk to you soon, and everybody, please just know that this should be inspiration to everybody to see kids in their practice, because what more could you know after you've gone to a course with Carla? So go there in October. Who doesn't want to be in Vegas? I mean, I know that she referred to it in a different term, but she did say the word strip. I think she said it's off the strip. But anyhow, strip off the strip, whatever. It's all the same. Hey, everybody go see Carla in Vegas. Thank you very much.
Thank
you.
Good night.
Good night, everybody.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.